Hi, I'm Dr. Brian Koffman, a retired family doctor and a CLL patient myself, co-founder, executive vice president, and chief medical officer of the nonprofit CLL Society. And I'm going to talk to you about a trial that should be of interest to CLL patients that was presented at the American Society of Hematology's annual meeting in 2021. And the title was a phase 1/2 trial of IL-7/IL-15 expanded bispecific LV 20.19 CAR T-cells for relapsed refractory B-cell non-Hodgkin's lymphoma. I'm going to unpack all of that and explain what it means. Dr. Nirav Shah and his colleagues presented this research for the American Society of Hematology's annual meeting held in December of 2021. So in the way of background, CAR T, or Chimeric Antigen Receptor T-cells, and we have a whole bunch of stuff on this on our website that you should check out, is a cell-based immune therapy that genetically trains an individual's immune system, specifically the T-cells, which are the type of white blood cell, part of the cellular immunity system, to recognize and attack cancer cells. CAR T processing involves taking cells from the patient and altering them to add a special antigen receptor specifically for different cancers. For example, for chronic lymphocytic leukemia, which is a type of non-Hodgkin's lymphoma, or NHL, CAR T cells are made to express a receptor for CD19, a marker found on the surface of all B cells. CLL is a cancer of the B cells. This allows them to attach to the cancer cells that express the CD19. But one of the challenges is that targeting CD19 can lead to downregulation of that protein by the cancer cells. And this can lead to a relapse of the disease with cancer cells that don't express the target CD19 on the cell surface. In other words, it becomes CD19 negative and escapes detection by the anti-CD20 CAR T therapies. So let's take a look at what they found in this trial. To overcome the limitations of the single-agent CAR T therapy, scientists developed a bispecific CAR T treatment targeting both CD19 and CD20. The research presented at ASH was from an early phase 1 trial with bispecifics that attached to both CD19 and CD20. CAR Ts manufactured through a slightly different process were previously reported, and we share a link with that. This is a phase 1/2 trial evaluating the safety of the LV 20.19 CAR T cells for relapsed and refractory B-cell non-Hodgkin's lymphoma. There were 22 patients that received the CAR Ts. Of these, 11 had diffuse large B-cell lymphoma, 8 had mantle cell lymphoma, and 3 had follicular lymphoma. I know you're saying, but there's no CLL patients. But often these are studied in our cousin lymphomas, and if they're efficacious there, then there's reasons to believe they will be efficacious in CLL. The median age was 63, and the median lines of prior therapy was 4. One dose-limiting toxicity, in other words, a problem that occurred that prevented doses from going higher, was when a patient experienced prolonged what's called immune effector cell-associated neurotoxicity syndrome, or ICANS. This is the neurotoxicity that people get. And another had grade 4, that's very severe acute kidney injury. There were 2 deaths from complications, infectious complications, pneumonia and sepsis, which is a bloodborne infection, that were unrelated to disease relapse. Many of you heard much about cytokine release syndrome that occurs, and this did occur here in 86% of the patients. Cytokine release syndrome is a condition that occurs after treatment with immunotherapies like CAR T. It causes a large release of cytokines. Cytokines are enzymes that go into the blood from the infected immune cells. This can cause many symptoms like fever, nausea, headache, rash, rapid heartbeat, low blood pressure, and trouble breathing. ICANS, or the neurotoxicity, occurred in 6 patients, 27%. It's another condition that occurs after treatment with immunotherapies, and it encompasses neurological events that can be from mild confusion, tremors, or difficulty communication, to severe problems like coma and seizures. Among all the patients, the overall response rate was 91%, with 55% of patients achieving a complete response. 17 patients had measurable residual disease testing 1 to 2 months after treatment, and 13 of those 17 had undetectable MRD. Among the mantle cell lymphoma patients, the overall response rate was 100%. Complete response was seen in 63%, and 6 out of the 7 that were evaluated for undetectable MRD were negative on day 28. At the last follow-up, no mantle cell lymphoma had relapsed in a follow-up of up to 5 months. So, let's look at our conclusions here. These results are encouraging and show that patients with relapsed refractory B-cell non-Hodgkin's lymphoma treated with this bispecific CAR T-cell had a high overall response rates and tolerably low levels of severe cytokine release syndrome and neurological toxicities. I spent a little extra time on the results with the mantle cell because they were particularly impressive, and this bodes well for the CLL community since they are closely related diseases with similar biology and targets. Loss of CD19 has been a documented cause of failure in CLL, though it does seem to occur less in CLL than in other lymphomas. We have a link to the actual abstract for your information on the website. Thanks very much for listening. I look forward to your feedback.